We sort of have thought about this from different vantage points and come, I think, to the same conclusion. So the approach that we took was we first started thinking about, well, how do they consider mitral intervention in people? And of course, they have consensus guidelines in humans, often based on outcome data. The North American and European guidelines recommend intervention, either TEER or surgery, for human patients with severe degenerative mitral regurgitation. We'll talk about what that means. Based on an integrative approach of MR severity, independent of diuretics or diuretic status. In other words, they do not consider B2 versus C to be a major factor in deciding which patients should get an intervention and what shouldn't. The patients who should get an intervention are patients who meet objective criteria for severe mitral regurgitation. Now, what does that look like? In humans, the ASC, the American Association of Echocardiography, has put out very clear guidelines on what constitutes severe MR. They recognize that all indices of measuring MR severity have limitations, so they recommend an integrative approach where you consider several things. Now, the approach that we took back in 2021, when we first started doing the TEER procedure, was can we develop or understand what constitutes severe mitral regurgitation in the dog? Some of the guidelines in humans can be directly applied to a dog. For example, a regurgitant fraction of greater than 50% constitutes severe MR in people, and that seemed reasonable to us. Others, like regurgitant volume, well, that depends on the size of the patient. So we looked at the available data in humans that predicts outcome as far as severity, and we came up with the guidelines on the screen here. And I'll let you basically read through them, but they're very similar to what Dr. Ricci just reported. E-wave dominant, greater than 1 meter per second, but especially regurgitant fraction greater than 50, regurgitant volume now greater than 1.2, and structural remodeling of the heart. So, in other words, if you look at B2 in dogs as it's currently defined based on the EPIC criteria, that includes dogs with a range of severity from mild to severe. And not all B2 dogs should undergo a procedure. However, to argue that that there are dogs in the B2 category who have not yet experienced pulmonary edema should not be considered for an intervention, I don't think that's a correct approach either. So, again, for the dogs that I'll show you data on, our initial criteria was, would they meet criteria for severity, independent of whether they were on diuretics or not. Now, if severity tells us which patients should undergo an intervention, then a second consideration that is termed anatomic complexity tells us whether a patient is suitable for an edge-to-edge repair. Now, one of the disadvantages, perhaps, of edge-to-edge repair or transcatheter is that not all mitral anatomies are going to be amendable to an edge-to-edge repair. An advantage of surgery is that it can handle more complex anatomies. And rather than a straight yes or no on anatomic complexity, as was originally defined in the original Everest trial, what's advocated now in humans is a tiered approach where complexity is judged anywhere from non-complex and ideal for TEER all the way through unsuitable. And we have identified, patients have come to Colorado for the TEER procedure that we have determined were unsuitable, and we have referred those patients for surgical repair, and they have been successfully corrected either at the Jasmine Hospital or University of Florida. And we appreciate having that option. So we could do a whole lecture on anatomic complexity, but to give you some idea of what we would consider to be different levels of complexity, a non-complex, a dream case, would be an isolated A2 prolapse with lots of coaptation reserve, that is, lots of overlap between the leaflets. A regurgitant jet that's eccentric and posteriorly ejected, and then especially on a commissural view, the vena contracta not being too wide. That is, if you imagine a single clamp coming in right here, that is liable to completely correct the mitral regurg. Now, we don't get to do a lot of greens. Most of them are more complex than this. So complex would be when both leaflets are involved. So the A2 and P2 segment are both prolapsing. When there's a vertical gap, when there's enough prolapse of the anterior leaflet that's creating a gap vertically, shallow coaptation, but the leaflets are still able to be in contact with each other, and a moderately wide vena contracta on the commissural view, you can imagine that if we put a clamp on this patient, there might still be leak around clamp. Very complex, this very billowing A2 prolapse. We do these cases. And we have learned how to capture this leaflet, but it can be more challenging. Loss of coaptation reserve, a very shallow coaptation, indicates a lot of dilation of the annulus with a horizontal gap. If that horizontal gap is too wide, then it's going to be difficult to capture the leaflets. A very wide leaf across the face of the commissure is less favorable. That could be a case for a double clamp if that's possible. But it also speaks to expectations. When we have the conversation with the owner about how likely are we to reduce the mitral regurg, on average, we reduce it a little over 50%. Some cases we completely abolish it, some cases we don't. What starts to look unsuitable for us, what we should probably refer for surgery would be a very severe flail. The leaflet is vertical, is pointing to heaven, as some of my colleagues said. A P2 flail is difficult. A point of maximum leak that's not in the central segment is probably not a good case for TEER. And then such a shallow coaptation that the leaflets are no longer in contact with each other. This is a patient that probably needs a surgical repair and an annuloplasty. Okay, so a little bit about the results. Usually in human patients, the first study is called the feasibility study. Can the device that's being developed, can you deploy it? Can it do what it says it's going to do? Can you do it reasonably safely? So last year, after some delay, we published the first 50 cases in a feasibility type trial. It just showed acute results. The procedural feasibility was 96%. There's a learning curve, and we were fortunate or unfortunate to be at the very head of that learning curve. So we had to learn about capturing the leaflets, who we should try to do it, who we shouldn't. But in the first 50 cases, we had 2 cases where we weren't able to capture the leaflet. If we saw those cases today, we would either not do them or we're experienced enough to where that's basically not an issue. Procedural safety was 96%. We lost 2 of these patients, or they died before hospital discharge. In that case, it was injury to the mitral valve. Again, a learning curve issue, something that is very unlikely to happen based on our current experience. I'll talk about the learning curve. The learning curve is steep. There's no doubt about that. And the first physicians and cardiologists to do this technique in people will agree with that. So these were our initial results. We just reported the acute results. It shows the level of severity here based on regurgitant fraction and regurgitant volume. Again, still the learning curve. We did break it out in the first 25 versus the second 25. You can see that we got better over the course of these first 50 cases. So now, and just based on Tuesday, we've done 134 cases. First case was in January 2021. The most recent case was this month. The average age of these dogs is 10 years. The body weight on average is 7 kilos. The smallest dog that we've done is 2.7. I know Dr. Weechie does smaller dogs than this, probably somewhere around 2.7 to 3 is as small as we can really usually do with the TEER procedure. About 28% were cavaliers. 40% of the cases that we've done are B2. But remember, they meet criteria for severe MR, so we think that they are appropriate cases. When we look at a little bit about, we talked about severity, how severe are these dogs? If we look at the first 126 cases, the average regurgitant fraction in these dogs is 61%, so they have severe MR. If we break that down versus the B2s versus the Cs and Ds, 57 versus 63, so still very severe MR in the B2s. Not all B2 cases are candidates for intervention, but some clearly are. Particularly cavaliers can have extremely severe mitral disease before they have their first episode of failure. Approximately now 25% of the cases that we're doing are double clamps. There's a size restriction here, but in order to get better and better reduction in the mitral regurgitation, we're becoming more proactive at doing double clamps. So let's look at some 2-year survival data. Again, we've been doing this since 2021. We went to Shanghai to see this device in 2020, January. We were there when things were happening. And then we were delayed a year because of the pandemic. But anyway, the data I'll show you includes the very first case we ever did all the way through now. So again, learning curve. If we look at freedom from all-cause mortality at 2 years, this is what it looks like. Now, these are older dogs, and as Dr. Weechie pointed out, some of these dogs die for reasons other than cardiac disease. But perhaps more importantly, if we break this down to freedom from cardiac-related mortality, the numbers look a little bit better. At 1 year, 80% of dogs are alive after this procedure, and in 2 years, 78%. What you can see here is the initial fall, which are all of the initial cases where things didn't go as well as you'd like, complications, etc. But once a dog after this procedure reaches about 2 months, then their likelihood that they'll be alive 2 years later is favorable, certainly compared to medical therapy alone. Dr. Weechie showed you those curves. For stage C patients, median survival is anywhere from 6 to 8 months. In this case, they haven't even reached median survival yet. Because people are asking and concerned about doing B2s versus CDs, if we look at the survival data in B2s versus C, basically, according to the hazard ratio, they're not different. They have similar survivals. Realizing that the B2s in this study are basically severe mitral regurgitation. If we look at remodeling, the data we have up to this point is out to 12 months. You can see that on average, the size of the left atrium and the size of the ventricle is reduced. Sometimes down to normal, but typically reduced. Perhaps more importantly, it does seem to be sustained at least out to 1 year. If we look at regurgitant volume, again, regurgitant volume per kilo is approaching 2.2 before. There is greater than a 50% reduction, and again, it's sustained. And if we look at regurgitant fraction, remembering that 50% or greater is considered to be severe mitral regurgitation in the human patient, 30% or less is considered to be mild mitral regurgitation. So at 12 months, on average, dogs have something close to mild mitral regurgitation after this procedure. Now, the next survival curve tells us a little bit about why this is important. If we break down how we did in reducing the mitral regurgitation immediately after the TEER procedure to less than 30%, which is mild, 30 to 40%, which is moderate, and more than 40%, what we see is that if we get it down to mild, 100% of the dogs are alive at 2 years. If we get it down to moderate, then the survival looks very similar. If we don't achieve that, then survival is not as good. But if we look at this curve compared to medical therapy alone, there is at least a suggestion that this is prolonging the life of dogs. So the data in humans, if you look at reduction of mitral regurgitation and their survival, it suggests that you do not always have to get the mitral regurgitation down to very low levels in order for there to be a survival benefit. Now, I typically have a conversation with owners, and I suggest to them that TEER should not be regarded as curative. Sometimes it is curative, or seems curative, but mostly we should think of it as palliative and an important adjunct to medical therapy alone. Now, a little bit about complications. This is something that we always need to share. 2 of these complications are not serious, and I'll show you the most serious complication, the reason why we sometimes lose patients. So, thrombosis. Basically, it's very low. We have seen a thrombus form around the clamp in about 3% of the cases. I think that's actually 4 cases. In every case, that has been treatable by adding an anticoagulant. So this is a typical case of a thrombus. You can see the thrombus here. It's quite small. It did narrow this valve. This was actually a double clamp. Thrombus actually seems to be more at risk for patients with a really good reduction in mitral regurgitation. But in every case that has developed a thrombus, it has resolved either in a matter of days or a couple of weeks with the addition of apixaban. And you could use enoxaparin, you could use rivaroxaban. I don't think it matters. You don't need to dwell on that. Mitral stenosis, of course, if you're bringing the leaflets together, you would naturally think there would be a risk of mitral stenosis. Certainly that's an important consideration in humans. You do not want to create a stenotic valve. Surprisingly, because these dogs' hearts are so dilated, mitral stenosis has been virtually non-existent. We've had one dog who had a gradient, intra-procedure gradient of 5 millimeters of mercury. That's considered to be the cutoff in humans. However, under anesthesia, you're probably underestimating that. That dog survived the procedure, but ultimately was euthanized less than a year later. So this was a small dog without a lot of remodeling, and it's generally not a big problem, but something that we have to pay attention to. And this is what it looks like. I won't go through that. Okay. Anybody that does this procedure, the TEER procedure, will tell you that what they worry about, the risk of the procedure at this point, once you're experienced, once you know how to go in and not injure the valve, is to put on a clamp and for that clamp to detach, leaflet detachment. So the risk of that is moderate, basically 5.9% to date. In 2 cases, we were able to rescue this by clamp detachment by going in and putting in a second clamp. But in the other 6 cases, this was a fatal complication. So this factors in a major way to our decision about whether we should attempt a TEER. How likely are we to capture these leaflets well? It factors into our decision to release the clamp. Have we captured the leaflets well? And it really is the thing that guides us as to whether or not we should do this procedure or attempt it. Experience plays a huge role with this, just like everything else. Okay, this was the first leaflet detachment that I had. This was case number 14. And maybe if you look at this case, you can see the posterior leaflet. I probably grabbed a cord. You can see the anterior leaflet is at 12 o'clock, the posterior leaflet is at 6. There's not a great bridge here. The clamp is tipping, that's not usually a good sign. And within 48 hours, this clamp detached. That's what it looks like. In this case, this was the first detachment we had. I convinced the owner to let us go in and try to put in another clamp, and we did that successfully, and this dog died of cancer almost 2 years later. However, they don't always have that kind of outcome. This was a double clamp. The mistake we made on this one, again, there's learning curves, but the mistake we made on this one was the second clamp was too small. So you can see that we've got 2 clamps, the second one's small. This clamp actually detached from both leaflets and embolized, but the problem is here that this is much worse mitral regurgitation than was present before. And you can see that in this case the leaflet was torn, again in our view because it was too small. So for the people who do this procedure, this is a list of things that we think about to prevent leaflet detachment. It's about case selection. It's about choosing an appropriate size clamp. We've learned not to undersize the clamp. It's about technique, capturing during diastole, and experience. If we look at the the learning curve in people, the Everest trial, the first MitraClip trial, 11% incidence of clamp detachment. Of course, in people, they have a rescue option of open heart surgery. Generally, they're not able to repair it. They can replace it. Now in the most recent trial, less than a 2% chance. So again, something I'm hoping that with experience, as we learn how to do this technique better and better, we can avoid this complication. Again, preventing leaflet detachment, I won't dwell on this. What are our options if the leaflet attaches? Medical therapy, but a lot of times they won't survive that. We can consider left atrial decompression. Surgery, the challenge with surgery is that they're usually not repairable in the hands of cardiac surgeons, so it requires a replacement. And a transcatheter replacement might be an option like that. Our goals moving forward: improve procedural feasibility, safety, and 30-day survival rates. Increase the percentage of cases achieving a MR reduction down to mild or less, 1+. That's an important goal now in humans. In human patients, they achieve 1+ in greater than 90% of the patients. Decrease the incidence of complications. Last slide. For those who might think about starting programs, and I hope that people will start programs as this procedure becomes more and more realistic. If we look at the human data, 275 cases in the TVT centers in the TVT registry, over 12,000 patients. The learning curve looks something like this. There's a major inflection point in procedural time, procedural success, complications after 50 cases, and it continues to improve up to 200 cases. So if we are going to embrace this technique, we have to, as surgeons and cardiologists, we have to understand that there will be a learning curve. If we look at the 20-year journey in people, there was a learning curve there, but if we embrace that, I think that we can have a procedure that complements surgery. It doesn't compete with surgery, it complements surgery. So, thank you.